So, good morning, everyone. I can see a few familiar names here. Happy that so many of you have joined. So, without further ado, let me start with the gLocal solution room. So, this is basically a week-long event across many countries associated with the gLocal and the JBI. And it starts from 3rd to 9th June. It will be ending today. And here, through this particular presentation, we want to sensitize you regarding what is JBI and what is its vision, mission, and how can you collaborate with such an organization. So JBI is actually all about providing better evidence for better outcome. And if you can see at the logo, this is what really makes it interesting, is that it has this ripple effect in the logo. That means we want to translate all this evidence and it should be applicable to everyone. Everyone can actually access it and use it. So that is the reason why this particular logo has been designed. And the JBI is currently headed by Professor Zoe Jordan, who's the Executive Director. And in the next few minutes, you'll be hearing from her regarding the gLocal solution room and JBI. So in a snapshot, JBI is a leading global evidence-based healthcare organization. And what they do is they synthesize evidence, they work in the transfer of evidence and also implementing it. And this is done majorly by educating everyone regarding how to actually perform evidence synthesis and how to actually implement it into practice. And JBI also has a software, many of you might be aware of it, which is called the JBI Summary, which we'll be talking about in the coming sessions, and actually how to do research and successfully translate it into practice. JBI has been working across 40 plus countries, of which one of Amrita is also a center. And this is being done by in partnership with experts across the world with a single motto, that is to improve the health outcomes. So the vision of JBI is better evidence, better outcome, thereby a brighter future. And it's all about promoting and supporting evidence-based healthcare, which is why all of you are here to learn more about this. So one of the reasons why our institute actually got interested in this particular evidence-based healthcare and JBI is because of this motto, that is, healthcare is more than just effectiveness. I think when we look for healthcare, we always think about effectiveness reviews, RCTs, and how to actually do a systematic review of RCTs and effectiveness thereby. But I think there's a lot more to evidence than this. That is, for example, how big is the problem? What is the burden? Which can be answered by a prevalence or an incidence review. And why is there an issue like this? What is the likely cause? Which can be answered by the risk and etiology reviews. And how does it make patient feel, or what do they prefer? Which can be answered by a qualitative review. We'll be talking all about that today. That is this portion. How does a patient feel about, or what do they prefer it comes to treatment? And what is the impact of the context, which is also very important because care across countries or across settings actually differ. And we really have to contextualize to make the evidence, to make sense of the evidence and apply it into our setting. So this is what we're all about, to answer different kind of questions. And JBI has 10 different types of reviews, which we'll talk about later. So this is a JBI model of evidence-based healthcare. You can see in the middle, it is all about the FAME approach, that is the feasible, appropriate, meaningful, and effective approach. And the wheel goes like this. You start with evidence generation through primary research, for which you need expertise. You generate the evidence. And then you synthesize it using what you're all interested about, that systematic reviews and evidence summaries and guidelines. And what actually happens is this synthesis has to go into practice, which goes through something called as evidence transfer, which is a very important step. And then finally, the evidence implementation, wherein all this evidence actually translates into policy or practice. And thereby we achieve global health. So this is the JBI model of evidence. And what we all, strive for is to bridge this gap. That is the gap between research. We all do research, but for it to translate into practice, that is the most important thing. And that is what we really need to focus on. Because as per the current data, for any research that we do to come into practice or policy, it takes around 17 years. So that is a long time. And everywhere, all around the world, we're working in generating good research, quality research, and then quickly converting it into practice. And JBI actually has a model for this, which is called the implementation model. So it's not just evidence synthesis. I would like to tell you all about, there's something called as evidence implementation, and proper frameworks are available into converting this evidence into practice, which is called the JBI implementation framework. And this has been done because of the support from different organizations. So the global reach of JBI is something I want to highlight on. And there are around 85 plus collaborating entities, and in our country, there are around close to 5 JBI affiliated centers. So this is one of the largest global collaboration to integrate evidence-based healthcare within a theory-informed model, not just synthesis, but also, implementation. And all these entities, including us, promote and support the use of evidence-based healthcare globally. And we are all leading in our own region, state, country, or specialty, so that the evidence that we generate can be contextualized to our setting. So just want to talk about center. Many of you are aware, we are called the Amrita Centre for Evidence-Based Oral Health, JBI Centre of Excellence. And we began in July 8th, 2021. And our vision is to synthesize evidence and improve the translation of this evidence into policy and practice related to oral health. We are a center for oral health. And we offer JBI Comprehensive Systematic Review Training Program, Scoping Review Workshops, and the JBI Evidence Implementation Training Program. We regularly conduct this, and one of the program is the JBI gLocal Solution Room, which is used to disseminate our activities and events. So we are the first JBI affiliated group to focus on oral health. We are the 4th JBI affiliated group in India and 76th JBI affiliated group in the world. So now the interesting part, that is what is gLocalisation. You must be, you must be thinking, what is this word gLocal? What does it mean? So what this mean is basically to think global and act local. That is what this concept is all about. So in the JBI model of evidence-based healthcare, what we really want to do is contextualize this evidence to the current setting. So we may be getting evidence from global data, but how to actually contextualize it into our setting is what that matters, and what that gLocal is all about. So it is building culture, capacity, communication, and collaboration, thereby contextualizing the evidence. So there is always say that working gLocally, that is a local knowledge disadvantage or local based disadvantage, it hinders the performance of evidence. So that is where we can use this universal knowledge and later contextualize it to our setting, so that we have improved outcome across international borders and cultures. So the same intervention or something that works in another country might not work here, but we can take that concept and adapt it as per our conditions. So that importance is given to that contextualization, and that is what gLocal stands for. So through this gLocal solution room, there is no magic bullet for translating what is known from research into practice. And to move evidence-based interventions to practice, we need several strategies. And what works in one context of care may not work in other. So that is the importance here, that is to bring in that contextualization. So to know more about JBI, you can access these social media platforms like Twitter, Facebook, Instagram, YouTube. JBI has an account in all these and get to know about the organization better. So that is regarding the introduction to JBI. Now there is a message from the director. Shweta, would you like to share the screen?
We are honored to have a special message from Dr. Zoe Jordan, the Executive Director of JBI. Dr. Jordan's word of wisdom and vision for evidence-based healthcare will inspire us as we navigate through today's session. Let's take a moment to hear her valuable insight.
Are you able to hear?
Yes, we can hear.
All right, thank you.
Hello and welcome to the JBI gLocal Solution Room. This is an event that's really designed to engage clinicians in getting evidence into practice. For those of you who perhaps aren't familiar with JBI, we really are all about getting evidence into practice. So using the best evidence to get good outcomes and create a brighter future. Now, in recent years, I've been thinking a little bit about this idea of a flywheel effect. And the original concept came from a guy called Jim Collins. And what Jim talks about is the fact that organisational change never really happens in one fell swoop. There's no magic bullet, there's no solitary lucky break. It's about having consistent attention to something to drive change and, to make organisational change happen. And I really felt like this has got some useful synergy with evidence-based healthcare and the forces that drive the successful translation of evidence into practice. Hopefully, most of you are familiar with the JBI model, and we've recently published a paper about the idea of an evidence-based healthcare flywheel. And what we did when we redeveloped the model in 2019 was to add these, we call them overarching principles, but they're underneath, so they're kind of foundational principles around culture, communication, collaboration, and capacity. And really we see these as the catalytic mechanisms that are required to successfully drive forward evidence-based healthcare initiatives in organisations. Now, we certainly recognise that evidence-based healthcare is relational. It's not transactional. And if we want to empower people to change their behaviour, then we really need to give some careful, thoughtful, and consistent attention to navigating the relational matrices that organisations are run by. Now, we don't want to reinvent the wheel, we just want to get it moving. And so, as you can see by this graphic, we really feel like those 4 C's that we added several years ago to the model are the drivers of the momentum required to get evidence into practice. And I think that's a really important focus area that we probably haven't paid sufficient attention to. We don't talk about them very much, we don't articulate them, but we know that they are the things that require attention in order to see change happen successfully. So I'm really excited that this week we have 35 gLocal events happening. Now you have to remember that this is an event that started as the local solution room here in Adelaide a few years ago, and really it was just an effort on our part to re-engage with stakeholders across South Australia. But when we shared the concept with our international collaboration, they were really excited by it. And so over the years, we've seen the number of events grow, and now we have an extraordinary number of events happening, which is just so exciting for us to see. We know that change can happen with just one pebble, with just one person. And so we're excited to see the ripple effect of change that came out of that one event. And we're excited to see the ripples that will now flow across the world. I hope that whatever event you're participating in this week, that you have a really enjoyable time. And I look forward to hearing more about them. Thank you.
All of you know that the topic of interest for today's session is bridging qualitative synthesis with practice and policy. So when you look at qualitative evidence synthesis, it plays a pivotal role in shaping evidence-based healthcare practices by providing a deeper understanding of complex healthcare phenomena. So today's agenda is packed with engaging sessions featuring our esteemed panelists. We have Dr. Vinita K, Dr. Kylie Audit, Dr. Monica Arora, Dr. Jaydeep Menon, and we have Dr. Chandrasekhar Janaki. So here today, we'll be delving into the introduction of qualitative evidence synthesis. We'll discuss how qualitative evidence can be incorporated into practice recommendation and explore into the influence on guiding policy decisions. Additionally, we will examine what clinicians seek in qualitative systematic review and how these reviews impact health outcomes. At the end, we'll be followed by a panel discussion, which will be led by Dr. Chandrasekhar Janaki. So first, let's dive into our first session. We have Dr. Vinita K, who is currently serving as a reader at the Department of Public Health Dentistry, Amrita School of Dentistry, Kochi. She is also the Deputy Director of Amrita Centre for Evidence-Based Oral Health. She is also pursuing her doctoral degree at Amrita Vishwavidyapeetham, and she is a national level trainer for evidence synthesis, qualitative methods, and data analysis, and has conducted multiple training programs across country. She is an undergraduate research coordinator for School of Dentistry from 2019. She is a reviewer in reputed dental journals and has 30 publications till date. Her area of interest is political economy of oral health, evidence synthesis, dental public health, qualitative methods, mixed method research, health economics, psychometrics, and tobacco. So Dr. Vinita will introduce us to the fundamentals of qualitative evidence synthesis. So let's welcome her to share her expertise with us. Over to you, ma'am.
Thank you, Shweta, for a lovely introduction. So hello, everyone. So it's my job to introduce you to qualitative evidence synthesis. Some of you might know me from the JBI CSRP training program where I've talked all about this. So today we'll just summarize what we have learned, how to actually do a qualitative synthesis. What are the different techniques available? So this particular session is concentrated towards that. So I'll share my screen. Okay. So let me introduce you to qualitative evidence synthesis, where I'll take you on what are the methods available and hook you up with few resources which you can use later and learn about this. So when we talk about qualitative research, we want to explore human behavior, attitude, or interactions. That is when we usually use qualitative research. While quantitative research, we want to measure something which can be, a number, and then make sense. That is where we use a quantitative research. So the basic difference is if you want to know in-depth information regarding a behavior, better to use a qualitative research. And some of you might be familiar with this. For those who are not, the methods used to collect the data is quite different from quantitative. So you will be collecting your data through interviews, observations, and you can also do textual analysis or content analysis of data, and then interpret and understand the concept, the behavior, or attitude. So that is what is qualitative research all about. And just to make a small comparison between quantitative and qualitative approaches are generally inductive, while quantitative are deductive. And the aim in qualitative research is to generate a hypothesis, while in quantitative, we want to test the hypothesis and understand it. So the setting for most of the qualitative studies would be the natural setting. For example, maybe a tribal hamlet, or maybe a hospital setting where the patient is comfortable. Or the natural setting is something that we always collect data. Or for quantitative, majority of the time, it will be an experimental setting or a quasi-experimental setting. We want to control all those factors. The sampling in qualitative is usually purposeful sampling, where we have an aim to collect this from this population. So each person is selected with a purpose. While in quantitative, we usually do it either probability or non-probability random sampling, and different techniques for that. And the data collection, again, it's different. That is, you'll be having interview guides or observational tools or textual analysis. While in a quantitative part, you will be mostly taking surveys through questionnaires, or measuring the data using any instrument or something like that. And the analysis for qualitative is always iterative interpretation. We do something called as a thematic analysis, or there are different types, framework analysis, which we can do. While in quantitative, we use the help of statistics and a modeling or prediction to understand and interpret the data. And nowadays, both of these techniques are combined together. You might have heard about mixed methods, where all of this comes in, and it's again another type of research which is really in boom these days. So the basic difference between a qualitative and a quantitative research. So the question here is, there is already a well-established quantitative research and techniques going on. Why and where does qualitative research comes in, and what is its importance in healthcare? So to name a few, What qualitative research can get you is the first-hand documentation of patient experiences. I think that is very important. We want to know how a patient feel and experience a particular treatment or a phenomena. We can understand from their first-hand perspective itself, like what could be the suggestions for improvement. And we can detect common concerns and desires associated with the quality of care, which we might miss through a structured questionnaire. Information about what matters most to the patient so we can deliver a care which they are comfortable with. And the opportunity to identify obstacles to growth and change, which you can use this particular research. And nowadays, qualitative research is widely used in implementation research, where they want to find out what the facilitators and barriers to a particular intervention. So that is a few examples. There are many more actually regarding how qualitative research is important in healthcare. You just have to find out in your setting, how can it be applied. So I'm just going through, for some of you might be beginners in qualitative research. So what is the general structure of qualitative research? So just like that, we'll be starting with a research question. Again, that's the most important part, and it has to be, the question has to be such that it can be answered using a qualitative research. Then you choose the best qualitative design. I think this is where everybody get confused. There are so many designs available, which one to choose. So this, once you study all these different designs and approaches, then it will be clear to you how to use and which approach to select. So qualitative design or quality approach, there are many, but the major three that which we say are the grounded theory, the ethnographic studies, and the phenomenological studies. And also there are some other types like case studies and historical studies and something called as action research, which comes into this implementation kind of research. So all of these different aspects are there, and we can select as per our need. And you have to have a good understanding of this to actually make a selection regarding which approach to choose. So once your design is ready, then you go ahead and do the sampling and recruitment. And again, purposeful sampling is what we usually do. Do your data collection using interviews or observation. Do the analysis, which will mostly be a thematic analysis or framework analysis. And then one of the reasons why qualitative research always is, we always doubt whether can it be applied into practices, whether does it have a sufficient rigor for it to translate into practice. So nowadays, there much stress is given on a qualitative study, which is done in a proper way, and a good focus is given on qualitative rigor, which I'll talk about a little later. So that is also important in the step structure of a qualitative research. What are the measures to ensure rigor? And then finally, reporting your findings. Again, there's a certain way to do that, where we'll be writing about the verbatims from our population, whatever data we have collected, it will be included in that. So the basic structure of a qualitative research. And I also want to stress regarding how to actually perform a qualitative data analysis. So the whole idea of a qualitative data analysis is about reducing the data without losing its meaning. So you have all these interview transcripts with a lot of information. So our idea is to reduce this data, but not to lose what it meant. So we do that through a process called coding, and there's different ways to do it. That is, you start with the code, you categorize them, you convert it into a theme, and then if needed, it can be converted into theory. So what basically a code, the name code means, it's basically a word or phrase or sentence which represents aspects of a data or captures the essence of features of a data. And you start with the codes and then condense it to a theory, like categories, themes, and then to a theory. So this is the basic structure of a qualitative data analysis. And there are many different ways to do it, whether it's manual or using a software. So just want to give you basics regarding that. Now, let's see if there are individual qualitative studies and how can we convert them into systematic review. So some of you might be hearing about systematic review for the first time. So systematic reviews are basically aim to provide a comprehensive, unbiased synthesis of many relevant studies in a single document using rigorous and transparent methods. So what we are trying to do here is combine all these studies through a rigorous and transparent way, and then make sense of that and pooling that evidence, or that is the idea regarding a systematic review. And with time, we have been focusing at the start, we have been focusing from effectiveness. Now we can focus on qualitative evidence synthesis because again, there are different individual studies, qualitative studies available, and we can definitely think of combining them and understand a phenomena better. So what is a qualitative evidence synthesis? It basically involves synthesis of qualitative research findings to generate new insights and understanding of a phenomenon of interest. This also follows the same steps as for any other type of quantitative reviews. That is, it is systematic and transparent approach. This also incorporates rigorous methods to collect the data. There is a good critical appraisal which we have to perform and then analyze the qualitative evidence. So if you look here, sorry. Yeah, so if you look here, yeah. So you can see how and where the qualitative research comes in. So if you have a synthesis where your aim is to configure something, then or generate a hypothesis, then you can use this qualitative evidence synthesis like meta-ethnography or thematic synthesis. And if you want to explore any data, a realist synthesis or a framework synthesis can be used. And if you want to test a hypothesis, then basically it will go for a meta-analysis. So this is the actually the paradigm of evidence synthesis, that is from configuring to aggregating. And this is initial stages is where our qualitative research comes in. So how can we apply qualitative research to practice? So as with quantitative research, results from a single study only should not be used to guide practice. So that is the idea of combining them together. So findings of qualitative research should be synthesized in order to develop recommendations for practice. And nowadays there's an increasing interest in the potential of qualitative evidence synthesis to inform this decision-making process in both policy and practice. So these are, some of you might be familiar with the steps in a systematic review. It's the same for qualitative research, and it gets customized after this stage. That is, from the critical appraisal, it gets customized to qualitative research. So this is basically how you go about in a systematic review. You have to start with a research question, define your inclusion-exclusion criteria, and based on this, you have to search for studies, locate them. And then through a screening process, you will be selecting the studies. And then you want to make sure the studies you're selected are of good quality, which you do it by something called as critical appraisal. And once that is done, you can go ahead and start extracting the data for your synthesis, continue with the data synthesis, present your results. And at the end, what we recommend is to establish confidence in results. So that's something you must have heard about, the grade approach. So I'll be talking a little bit about that too. So that is, after your final review is done, how confident are you in your findings? So that there is a way to actually make that is called establishing confidence, which we'll talk about later. So this is the general steps in a qualitative evidence synthesis. And we'll go through each in a very brief manner to give you a bird's eye into what happens in each step. So first is a research question. So the format, there are different acronyms for research questions. So one of that is the PICO format. So it's a little bit different from the other PICO, which is a population intervention comparison outcome. Here we have a little bit different. So it's PIC and small o, where P is for population, I is for the phenomenon of interest, and C is for the context. So if you're planning a qualitative systematic review, your research question can be through any of these. So it can incorporate these elements, and there are many other types of acronyms available which we can use. So there is something called as a SPIDER acronym, which talks about sample, phenomenon of interest, design, evaluation, research type. There is something called as a SPICE, which is concentrated regarding setting, perspective, interest, comparison, evaluation. And this is one of the latest one for a qualitative research question, which is called the perspective. Very intelligently, they have framed it. So it's basically perspective, setting, phenomenon of interest, environment, comparison, time, or findings. So it's up to you which one you want to choose. So as per your topic, you can select any of these. You just need to report which one. That's the only thing cached there. So these are few different types of research questions, formats available, which you can customize to your research question, research problem. Now the question, once we are ready with our research question and the inclusion exclusion criteria, where should we search for qualitative studies? So initially, even I struggled, we didn't know where to actually make a search. Is Medline search enough, or should we search for other databases? So now with time, there are some guidelines available that is going to help us to locate these qualitative studies. So this is an article by Andrew Booth, where the article focuses on searching for qualitative research, how to actually go about it and which databases to use. So I've just made a small gist of what this particular article stands for. So it suggests that reliance on Medline alone is particularly discouraged. So always include different types of database, not just one. So CINAHL and DIMDI, which is a German database, actually yielded a higher number of relevant hits. I think CINAHL is one of the very good database where you can locate qualitative studies. It is one of the first databases to introduce qualitative studies as a mesh term or a medical subject heading. So if you want, definitely do include CINAHL if you want to locate qualitative studies for your subject. And it's also very important to look into gray literature, because majority of the studies you can locate through gray literature. We had one experience recently where we were working on a topic called as collective spirituality, where all of these standard Medline and couldn't actually give us more data. So when we looked into the gray literature, we could actually locate more studies. So I'm going to give you a few examples into where to actually look for when it comes to gray literature. So you can have a look at the conference abstracts of proceedings like BIOSIS, Citation Index, Web of Science, Scopus, all of these publish conference proceedings and ProQuest conference papers. So all of this you can have a look and see if any studies are there. You can also have a look at unpublished PhD theses and dissertations. So there are many dissertation repositories available across the world, like Ethos, WorldCat, and all that, or open access thesis and dissertation. You can have a look and see whether anything fits into your inclusion-exclusion criteria. There are also other gray literature databases like OpenGray, Gray Literature Report, and TripPro. All of these are a few databases which you can look into and locate the studies. So these are basic, and you can also include other standard ones like Scopus, Web of Science, Embase. Usually better to include a wide range so you don't miss any particular studies. So the next important step after you've done with your study, after you've selected your studies, you finish your title and abstract and full text screening, is to go for the critical appraisal. So this is something we all look into, okay, how to actually ensure rigor in the qualitative database, a qualitative systematic review. So there are a few terms which you can use. For example, in the quantitative, there is something called as reliability. The concept is that if a person repeats the same thing, will they be getting the same results? So something like that we can apply in qualitative, which is called as dependability, in which we say it's not getting the same data, but rather getting the same quality when you repeat the study. So that is something called as dependability. And then there is something called internal validity, for which in qualitative we say something called credibility, and external validity, which we can think of it as a transferability. That is for this particular results to be applied to general population. So there are a few methods which we can, just like how we do blinding or matching or something like that. There are a few methods for each of these, and you can look into the article primary studies and see if that has been followed. If that has been followed, then we can say, okay, credibility has been maintained or transferability has been ensured. So something like that, you can have a look. There are a few examples. For example, there is something called as member checking. There is something called as research triangulation. All of these things actually give more rigor to the individual primary studies. So it's just different things that you can take into consideration when doing a critical appraisal. And there are a few checklists available. Because you must have heard about the JBI checklist for qualitative research. So these are questions and individual studies we need to answer with each of these questions and see how far they've adhered to risk of bias or rigor here. Okay. So qualitative checklist has around 10 questions and a JBI checklist has around 10 questions, and you can apply it and assume and measure the quality of the individual study. And there is something called as CASP or Critical Appraisal Skills Program, which again has a 10 question, and this can also be applied. So it's almost similar. You can choose whichever one you want and use it to do the critical appraisal. So after your critical appraisal, you will start with data extraction, in which it's usually done in two phases. The first phase will concentrate regarding the study characteristics. So what is the nature of the population? What is the context? What are the study designs used, methods used to collect data? Just basically everything just regarding a study is something called a study characteristics. You'll have a characteristic include studies table there. And then you will be extracting the results from the individual studies that most probably will be a finding or an illustration from the study. Now, the second part is actually guided by the data synthesis approach you have adopted in a qualitative systematic review. So there are different data synthesis approaches like thematic synthesis, framework synthesis, meta-ethnography, and the JBI approach, which is called the meta-aggregation approach. So many of these are available, and your data extraction will actually depend on which type of synthesis you're doing. So it's just a gist of, I don't want to complicate too much, but just for you to understand that there are different types of synthesis available with a particular aim. And if you look into it, there are thematic, narrative, realist, content analysis, meta-ethnography, and meta-aggregation. So for meta-aggregation, we require a protocol, but others it's not mandatory. And definitely exhaustive searching is required. And in a meta-aggregation, we try to locate all these sources and do a proper exhaustive search. And critical appraisal is important for meta-aggregation, while others it's optional. If you want, you can include, otherwise you may not. For meta-aggregation or a qualitative systematic review using JBI approach, it's mandatory. And the approach synthesis is very different in each. For a thematic, you'll be arranging it into themes. For a meta-ethnography, you will be doing something called as translation using three different kinds of translation, like reputational synthesis, reciprocal translation, and line of argument synthesis. I know it's might be a bit unheard of, but I'll talk about it a little later. So the meta-aggregation is basically all about aggregating the findings into categories and converting them into synthesized findings. So I'll give an example for meta-ethnography and meta-aggregation, how to actually go about it so it's more clear. And the most interesting thing is that this is applicable across all these methodologies. For example, you have a grounded theory, you have your phenomenology. So any of these data synthesis approach can actually be applied to all of this. So for example, in a quantitative systematic review, if you're doing an effectiveness review, you will be only concentrating on maybe a RCT or a quasi-experimental. But here you can synthesize data across study designs. There's no restrictions on one study design. So that is in line of agreement with all the approaches for data synthesis. So synthesis across different methodologies, which means any different methodologies like phenomenology, ethnography, or grounded theory, using different methods can be mixed in a single synthesis of qualitative studies. Obviously, they should focus on the same phenomena of interest. So our idea in meta-aggregation is to focus on study findings and not just the data. And this is the critical assumption of meta-aggregation. So now all of these are available, these different data synthesis. Actually, which one to select, you might be a little bit confused. So this flow chart is actually a good way to go about it. So if you are planning to do a qualitative systematic review, and your idea is to aggregate or summarize the qualitative data related to a specific question, then you can go ahead with a thematic analysis or a meta-aggregation where you just want to summarize the findings. And in the end, you will get an aggregated findings from all these source papers. So this is the first one where you want to aggregate or summarize the qualitative data. But in the second one, if you want to interpret the data in qualitative synthesis and make a theory or any explanatory model, in that case, you have to use the approach called the meta-ethnography approach or a thematic analysis along with a theory generation or a grounded theory approach. And if you want to integrate it with quantitative evidence, for example, you're doing a mixed method review, and then develop an explanatory theory. You have other methods like realist approach or epi approach or a narrative synthesis approach. So from this, the product will be an explanatory theory or an analytical or a conceptual framework or an interpretive framework. So this actually can give you an idea on to which approach to actually go about. So the major two approaches are meta-ethnography and meta-aggregation. And meta-ethnography has been developed by Noblet and Hare. There is a seven-phase approach. I'm not going to go into too much detail into this, but what is important is the process which makes it different from other approaches is something called as translation. And there are three types of translation which you do and to perform analysis. So first is the reciprocal translation, where the concept in one study is incorporated into the other. A refutational translation, where concepts in different studies contradict one another. And finally, the line of argument synthesis, where studies identify different aspects of the topic under study and it is combined together to make an interpretation. So there is a way to do this. Again, I can't go too much detail into this, but just understand that there is something called as meta-ethnography, which has 7 phases and wherein translation is being performed, where each of the primary studies are juxtaposed and their relationship is being studied. And what we follow here is the meta-aggregation using the JBI meta-aggregation approach. And these are the 5-stage approach to meta-aggregation. As I told earlier, it's mandatory to do a critical appraisal before synthesis according to JBI format. And then you extract the study details. So first you will have the characteristics of included studies, the method, phenomenon of interest, all that. And then you have you will be aggregating the themes and sub-themes, which is basically the verbatim and an illustration to support the verbatim. I'll give you an example. So just going through the process. And once this verbatim and illustration quotes are available, you're going to combine them together and categorize them. And then again, these categories can again be combined to produce something called as a synthesized finding, which is just a comprehensive and representative conclusion for all these categories. And what makes this approach a little bit, interesting is at each level, we are assigning something called as a level of credibility. So I'll talk about that. So there is something called as a level of credibility. To each findings, we'll be applying that. So I'll talk about that in the coming slide. So this is generally how we go about meta-aggregation. After extraction, you will collect the individual findings accompanied by a verbatim, and each of these findings will undergo a level of credibility, which I'll talk about later. So how to actually identify a finding and an illustration? So in a qualitative primary article, if you go to the results section, mostly it will be depicted as a themes along with some verbatim quotes. So here you need to categorize them into a finding and a finding which is supported by an illustration. So what is a finding is basically a verbatim extract of the author's analytic interpretation of the results of the data. So you can't actually change it. Whatever the authors have written, you have to take it as such it is, and that will be your finding. And this is actually accompanied by an illustration, which is actually the original word from the patient or the subject of interest. So you have to extract an illustrative excerpt that the researcher presents in support of that particular finding. So this is how the process of meta-aggregation starts. You will list all these findings, which will be accompanied by an illustration. And then each of these findings, you need to give a level of credibility. And there are 3 sections for that. So first is unequivocal, credible, and not supported. So unequivocal basically means your finding is accompanied by an illustration, and these two are they match together, and this illustration is beyond reasonable doubt and is not open to any challenge. So they match, and the verbatim is actually supporting the finding, which means it's unequivocal. There's no issue there. And the next could be credible. So for a finding, there is an illustration, but it doesn't really not match that much. So there is a lack of clear association with it. Therefore, this link is open to challenge. That is something called as credible. And sometimes you will have a finding, but you will not be able to locate any verbatim extracts for that or an illustration for that. So when both of these doesn't apply and the findings are not supported by the data, then you will include you have to say it as not supported. So in the meta aggregation, you'll only be taking those findings which are either unequivocal or credible, and you'll be listing it down like this. If you can see in the brackets, each finding is accompanied by a level of credibility. And then you combine them together and make meaningful categories from that. And then finally, you again combine these categories and it will go into a synthesized finding, which is a conclusion of these categories with a line of action. So that is how a meta-aggregation approach looks like. So with this stage, we'll have these synthesized findings, which is, you can compare it something like an outcome in any quantitative research. So each synthesized finding will be an outcome. Imagine it to be like that. But the catch here is how confident are you in your synthesis and how confident are you in suggesting this particular synthesized finding. So that we need to do by something called as the grading of evidence. You might be familiar with something called as the grade approach. So the grading of evidence is done by the summary findings table. This approach establishes confidence in the synthesized findings of qualitative systematic reviews. And there are two approaches to grade the evidence. There is Cochrane Serqual and qualitative Conqual. So I'll talk about Conqual, but I also wanted to know that there is something like Cochrane Serqual also available. So basically, for each synthesized finding or each finding, they'll be assessed using these components and you'll be establishing the confidence in that. For example, is it high confidence? Is it moderate confidence, low confidence, or very low confidence? And the readers or your audience, when they read it, they'll understand that, okay, if it is of high confidence, yes, I can apply it into practice. If it is low, then it may need few more data to actually apply that into practice. So luckily, something like this is available. It's called the grade of the recommendations, which is widely used. And Cochrane Serqual is available for qualitative evidence synthesis. And what we follow is the JBI Conqual, which is again the same thing with a different criteria. So here the ranking of the confidence is done as high, moderate, low, and very low. And all of the findings start off as high. And based on few criteria, they'll be downgraded or upgraded. So there is something called a score of dependability, which is based on 5 questions. And based on these 5 questions, we'll see where it stands. For example, if it's 4 to 5, if it's 4 to 5 yes response, then it will stay at high. If it is 2 to 3, it will be downgraded to moderate. And then if it's 0 to 1, it will be downgraded to low. Like that, it goes. And then there is something called a score of confidence, which is basically from your levels of credibility, that is unequivocal, credible, and not supported. If all your synthesized finding has unequivocal finding, that is, there's no open, it's not open to challenge, then it will stay at high. And if it's a mix of unequivocal and credible, it will be downgraded. So far, like that, it will go on and it will be downgraded. So this is how we do a JBI Conqual. I know it's a very quick introduction to this. And this is how your summary of findings table looks like. So this is one of the studies which we did, where we want to identify what are the socio-cultural factors affecting the initiation of smokeless tobacco. It's a synthesis of qualitative studies, and we could get 3 synthesized findings from this. And the type of research is qualitative. And again, dependability, we did it based on the critical appraisal, based on those 5 questions. And based on that, we have downgraded it and upgraded like that it has gone. And credibility is based on the number of the levels of credibility, that is whether it's unequivocal or credible or unsupported findings which we could get. So based on that, we have upgraded and downgraded it. And finally, combined together, we have done the Conqual score. I know it's just a very brief introduction. You can learn more about it once you start doing a workshop or a grade workshop. So this, it's systematically is actually a rigorous process, and you really need support from softwares to assist to perform this. So there are different softwares available. You must have heard about Covidence, Ryan, and Cadima. So these are all, you can use it to actually upload the results, do the screening, data extraction, all of that, you can use it. But when it comes to synthesis, I think you need the help of other type of database, other type of softwares for qualitative systematic reviews. So there is something called as NVivo, which is a qualitative data analysis software. You can very well use that for your qualitative systematic review. And I also want to talk about the JBI software, which is called the JBI Summary. Actually, this actually is one of the only software which provides end-to-end support to perform a qualitative systematic review. And if your resources are limited, you can even do it with the help of an Excel or a Google Sheet, or use a reference management system like EndNote, X9. All of these have features which can help with assisting the qualitative systematic reviews. So I want to talk about the JBI summary. Most of you may have access to it, and might be familiar with this. So JBI summary actually is one of the only databases which provides support for qualitative systematic reviews. So it provides systematic process mirroring that of systematic reviews of quantitative research, while sensitive to the nature and traditions of qualitative inquiry. So you can see it's all, the headings are all similar to any other type of systematic review, where in which the contents would be different. The protocol will be customized to a qualitative study. A critical appraisal tool that you can access here would be a qualitative systematic review tool. Extraction again will change, and in the synthesis there is a separate option for qualitative data synthesis, which looks like this. So I hope you're okay with a meta-aggregative approach. So all your findings from each of the studies and their accompanied illustrations can be put here. And you can also assign the level of credibility and then later categorize them, convert them into synthesized findings, and finally make a meta-aggregative flowchart. That is a visual representation. So all of this you can do with the JBI summary, and we really promote this if you want to try to do a qualitative systematic review. Now, after you have done all this, how to actually present the review results and to finalize the reports, it is done using these headings. So you have to mention clearly how did you include each study, how many people performed the screening, and what was the process, and ultimately how many studies did you include. What is the methodological quality using the checklist from JBI or CASP, what do the critical appraisal, and then write about the characteristics of included studies. What are the nature of the each individual studies, and how to get a complete idea regarding that study. And finally, you have to write about the findings of the review or results of the meta-synthesis of qualitative research findings. And then again, the sections are quite similar to a quantitative systematic review. You have to write the discussion, the conclusion, and then recommendations for practice and recommendations for research, in which grading can really help. And as far as the current standards are concerned, you are supposed to register a qualitative systematic reviews. That is the first step which you will be doing. And Prospero accepts qualitative systematic review. So that's good news for that. You can directly register in Prospero and get that number. And there are also other options. In case your review gets rejected from Prospero, you can look into Figshare or Open Science Framework, which accepts registrations from qualitative systematic reviews. And your reporting checklist is as per the Prisma 2020 checklist, is the latest one. And this is used for all other types of systematic reviews. You can use the same here and report your findings. So that's all regarding introduction to qualitative systematic reviews. There are many resources which are available for you. There is JBI Manual for Evidence Synthesis, and Cochrane has also developed one, which is called the Cochrane-Campbell Manual for Qualitative Evidence Synthesis. You can access the JBI Critical Appraisal Tools, CASP. There are very good articles on how to do a grading, whether using the CERQUAL or the QuantQual approach. And you can use the JBI meta-aggregation, learn more about it from the JBI evidence implementation. And you can learn about other types of synthesis like meta-ethnography. There are many articles available for that. So these are few resources which are available. And next month, we are actually conducting an in-person training, which is the 7th CSRTP at our institute in Cochin. And we have a seat limit of up to 10. And there is a module exclusively dedicated to qualitative evidence synthesis. If you're interested, you can contact us for that. And in case you're not able to attend this particular CSRTP, just understand that there are many different organizations in JBI in different areas, which actually provides this CSRTP and scoping review and also evidence implementation workshops. Just need to visit JBI website and find out from there and choose your region and wherever you're comfortable. There will be online as well as offline events. So there's actually no boundaries. You can, whichever works for you, you can select and undergo the training. So that's it. I know it's been a rushed presentation, but I hope I could make you understand a little bit regarding what are the steps involved and few names of qualitative evidences which will help you in actually performing it. So obviously we have to, the theme is to think global and act local. So with that, I stop the presentation. Thank you.
For setting the stage for our discussion today. Your insight have laid a strong foundation for our exploration for quantitative evidence synthesis.
Thank you.
So if anyone have any question regarding it, they can.
Yeah, this is Dr. Nagesh here. Can you hear me?
Yes, sir.
Hello, sir.
Hi, Dr. Vinita. How are you guys doing? All
We're
okay?
doing
How is the
really
team
well.
doing? Great.
Team
So
is
thank
doing
you.
great, sir. Yeah.
Thank
Happy
you.
to have you here.
Yeah, thank you. I'll be hopefully I'll visit you guys in next month. I'm coming to India, so
Oh,
I can
wow.
meet you
Yeah.
guys also. Yeah.
Sure.
Yeah. Dr. Vinita, just wanted to ask you about the renewal of JBI Summary software. Last time it was in a complimentary with the workshop. And now you guys have something which is associated with the workshop and thing like that, or is it you have to?
Yes, sir. You can write to JBI Summary actually. I can provide you. I'll mail you the email ID. You can just write to them and they'll let you know regarding the subscription rates and all that.
Okay.
Yeah, so that would be good. So I'll share that mail ID with you very soon, and you can mail to them and they'll clearly give you a picture on how to get this particular software access.
Okay. No, I mean to say that is there any as a further discounted as before you guys gave us? So in the same way, is that the same thing? I mean the standard rate, or just a curiosity question? Is it associated with any workshop or something like that?
Yeah, so it's usually you can purchase it it's complimentary with a workshop, but if you want to purchase it, once your subscription is over, you have to go and purchase from directly from the JBI Summary, the team from there. Yeah, so that is how it goes. Yeah.
Okay, thank you, Vinita.
Thank you. Happy
Meet you,
that you're here.
meet you guys. Yeah, meet you guys soon. Okay.
Oh, very excited for that. Thank you.
Yeah, thank you.
Anyone have any questions? Please write it in the chat box so that we can discuss it during the Q&A session. So our next speaker, I'm going to introduce my next speaker, which is we have Dr. Kylie Porritt, the Director of Transfer Science Division at JBI and the Editor-in-Chief of the JBI EPP database. She has been an active contributor to the field of evidence-based healthcare for nearly 2 decades. She leads a team of dedicated, passionate researchers and together collaborating with local and international stakeholders, develop rigorous, trustworthy, evidence-based resources to inform and guide clinical decision-making and practice. Her area of interest is advancing methodology for clinical decision-making resources, methodology for meta-aggregation, JBI's approach to qualitative evidence synthesis, and Conquel, JBI approach to assessing confidence in the qualitative synthesized finding. So today she'll be taking a session on incorporating qualitative evidence into recommendation and practices. Welcome, ma'am.
Excellent. Thank you so much. I will share my screen. Sorry. Yeah, can you see the slides?
Yes.
Excellent.
Thank you.
Great. Thank you. Thank you for the lovely introduction and a wonderful presentation, Vinita. That was packed filled with lots of information and really useful links, and yeah, really wonderful to see the bigger picture and hear other people present the information. So first of all, I just want to say thank you for inviting me to be part of your gLocal Solution Room event this week. This is my second one for the week. We had the one in Adelaide on Thursday, which was really exciting. We had lots of representation across our health networks in the state, and our event in Adelaide was focusing on fundamentals of care, which is something else that I'm passionate about. But I'm very passionate about qualitative evidence, so I'm very excited to be talking to you today. I will just start with some disclosures. So I am employed by JBI at the University of Adelaide, which is based in Adelaide, South Australia. So most of the things that I will talk to you today is about the JBI approach towards qualitative evidence and synthesis and how we apply and connect qualitative evidence synthesis to practice. I am also the chair of the Evidence at the Point of Care methodology group. So this is our clinical decision support resources, which I'll be talking about today. So I chair the methodology group, which drives the science behind how we are actually developing those resources. And I am the chair of the JBI Qualitative Methodology Group. I have been the convener. I've been part of the Qualitative Methodology Group for a long time. I was reflecting on, as you were talking, Vinitha, I was actually involved in the sessions where meta-aggregation were developed. I was a very junior researcher then, so I didn't look the way I looked now, but I was involved with all of the other qualitative health researchers where they came together in a room and over a week were talking about how we can synthesize qualitative research. And that was a really new concept back then as well. So it was, Vinitha explained, went through all the different types of approaches for synthesizing qualitative evidence that we have today. 20 years ago, that wasn't the case. It was a really innovative idea. And, there was lots of discourse around whether we should even be doing it. So, my PhD was focused on the use of qualitative evidence to inform practice. And I think now when I reflect back on that, it wouldn't even be a PhD now because it's just assumed that, of course, qualitative evidence can be used to inform practice. But back when I did my PhD, that wasn't the case. So it's great to see the advances of where we've moved along in the realm of qualitative evidence. And today I'm going to be talking about how we can connect that evidence to practice with a particular focus around best practice recommendations. So some of the information I'm going to present has been touched on today already, but I think that's okay because it just means it sort of sits, you get to hear it again, it eventually will sink in. So we'll get started. So I am part of JBI. This is, I think, maybe the third or fourth time you've seen this model. We're very proud of this model. But what I wanted to focus on in this part of the model today is when I'm talking today, I'm really talking about the blue, the purple and the orange wedge, and with a particular focus on the purple wedge. So evidence synthesis is obviously where what we're talking about today, qualitative synthesis, and that sits within the blue wedge of synthesis. I lead the transfer team, so that's the middle. We are wedged right in the middle of synthesis and implementation, and our role is about connecting the evidence into practice. And so everything that we do as a team is really focused on how can we best do that. And part of that leans into the synthesis side, and part of that will also lean into how we help move it into the implementation side. And so I'll talk through some of that today. So being the transfer and connecting evidence to practice, this is what we're aiming to do. I think Vinitha spoke about how there's 17 years of gap between research and practice. I quite liked this particular side because your event today is on bridging qualitative synthesis into practice, and I felt like they're building that bridge. So they've got the ladder in their hand, they're trying to connect it over, and hopefully throughout the presentations today we'll be able to find some strategies and start some discussion around how we can actually close that gap, build that bridge, and see more of evidence getting into practice. So what is qualitative research? So this is just reiterating some of the points made earlier, but it is really about understanding human behaviour, understanding how people experience things, and it also looks at how people have social interactions, how cultural preferences can influence how people access healthcare. So it really is all things around understanding human behaviour. And as the name qualitative synthesis, in terms of its data, it uses non-numerical data. So we're not talking numbers, we're not talking lots of statistics. It uses text, graphics, so lots of words, lots of summaries, really to try and unpack and understand human behaviour and connection. And at the bottom, I've got a quote there by Denson and Lincoln. And really, qualitative research is about examining people in their environment. So looking at how people interact, engage with one another, and understanding more about creating in-depth knowledge about a particular phenomena of interest or an area of practice in order to bring deeper meaning and be able to have that information influence and inform how we make decisions regarding healthcare. So why is it important? And there's many reasons why it's important, but these are just some that have just been highlighted. It helps with understanding complexity. So qualitative synthesis does help address some of those issues around complexity, and we all know that healthcare is getting more complex. Patients are coming to hospitals with more complex issues. Lots of things can sometimes be challenging, not working. So to understand what some of those issues are, qualitative research can help with that. The findings and analysis that we get from qualitative research can be used to inform policymakers' decision-making, our practice decisions. It can be useful for identifying patterns and trends, and these can be complementary along with with effectiveness approaches as well, and being able to do that. One of the things that qualitative research is particularly good at is unpacking and understanding diverse perspectives. And I think that's really important, especially with ensuring that everybody has equal access to healthcare, understanding what how their experience for a particular healthcare condition or how a particular group some challenges they may feel when accessing healthcare. Qualitative research can really help us understand that a bit more. It also helps with the cultural sensitivities. Qualitative research provides us with really nuanced information, and I think that's a really important point, that it's done when we're not there to generalize across, but to really understand and hope that this information can be used usefully for practice, and it can help with impact as well, enhancing impact. So Vanitha did have a slide that we've got very similar slides, Vanitha, which is great to see, but I won't touch too much. And I just really wanted to make the distinction between the difference between quantitative and qualitative before we start getting into the recommendations for practice. So as been mentioned earlier, quantitative research is highly structured, and qualitative research is very much less so. The objective of quantitative research is to sort of, not just determine cause and effect. That's one aspect of it, but it is a very structured approach, where qualitative research, we're looking at describing relationships, explaining how things work. It uses the non-numerical information as data, so words, images, objects. So I think, excitingly, we'll see a shift in qualitative synthesis and how it's done, because predominantly it's focused on the words and how we summarize words and how we unpack and generate deeper meaning of words. But there is, over the last few years, there's definitely been an increase in other types of data that can be used and can be useful to informing practice. And in some cultures, words are not what they in some cultures, words isn't their preference as well. It might be images that they use. So I think we're heading into some really exciting times as to where qualitative synthesis is going to be. And there's obviously different methods in how we conduct between the quant and qual. But the purpose or the outcome of qualitative research is really to provide that deep, detailed, rich description and offering that insight into what is going on in a person's experience. So also, just to reiterate some of the information that you've heard today, these are the different approaches. I mean, I could spend a whole hour just talking philosophical approaches on qualitative research and synthesis, but essentially there's two paradigms of thought which relate around the interpretive paradigm and the critical paradigm. So interpretive seeks to understand and interpret, and uses approaches which you may be familiar with, such as phenomenology, ethnography, and Benita touched on some of these today. I do feel that if you're interested in qualitative research, going off and doing extra reading around each of these different approaches is really useful. And the critical paradigm seeks to sort of create change, challenge how people are thinking. And action research is one of the more frequent or common approaches that is used in order to achieve that. So these are just some examples of qualitative research. These have been published in the JBI Evidence Implementation journal, and this particular study is looking at how healthcare professionals prioritise clinical areas. So I think this is a useful, I just wanted to sort of demonstrate some ways in which, why you would conduct qualitative research. So understanding how people choose and select, so not just using numerical data. I think that people are thinking about how we're going, what will our implementation topic be. It might be the one with the highest incident rates, where, and you'll choose a numerical, but there are some other reasons why you might choose a clinical implementation topic, evidence implementation topic. So this is an example there. And also in understanding how things work. So this paper here is about learning more about how people experience facilitation during implementation, what challenges they might have faced, did they think it worked, and using that information to improve how we facilitate people to move and shift evidence into practice. And then this one here is, I just wanted to show, this is another way of how qualitative research can be utilised in a broader aspect. So this is looking at how building an implementation strategy for Colombia. So looking at community-based rehabilitation for mental health in Colombia, and they were using a qualitative approach in order to be able to do that. So you can see how qualitative research can provide some really useful, nuanced information. So when we're thinking about how we make our decisions, and when we're going to apply our research into practice, how do we come up with a decision? I'm sure everyone's familiar here with this Venn diagram. So the evidence is one part of it, but there are patient preferences, our professional judgment, the context in which we're delivering it. And so obviously when we might be talking predominantly about the evidence, it is useful to know that it is just one aspect of how we make decisions. And when we're thinking about the evidence, it's not just evidence of effectiveness, as we've heard this morning. It's thinking about, is it feasible to be able to do this particular intervention, this approach? Is it appropriate to do this in the context that I'm in for the person that's presented before me? And is it meaningful? Is it going? And so this is where qualitative research fits in being able to provide a connection to our decision making. So the role of qualitative evidence synthesis in practice, so I've spoken mostly about just qualitative research generally, but in terms of qualitative evidence synthesis, the term itself is generally referred to as a broad umbrella term. So as Benita demonstrated in her presentation, there are a range of approaches to undertake qualitative evidence synthesis. And recently, and I think there are a range of different terms that people use as well, but more recently there seems to be an agreement that qualitative evidence synthesis is the broad umbrella term that collectively describes all of those different approaches. And the role that qualitative research has with qualitative synthesis has within that is, again, as saying, to understand a specific phenomenon, a context or experience, and it has a significant role in how understanding how individuals and communities perceive health. And I might feel like I'm being a bit repetitive, but it's deliberate. I want to really try and make sure that you walk away from the presentation understanding really the important role qualitative research has for our healthcare decision making. It can increase our understanding of different cultures, as I was talking about before. The evidence can be used to inform practice, policymakers, healthcare providers, and it can be used as a complementary aspect as well to quantitative approaches and to be able to evaluate how things are working. So JBI has developed an approach to qualitative evidence synthesis, which is meta-aggregation. So I'm not going to go into too much detail about this, but there is interesting. The methodology group is in the middle of updating their guidance. So we are hoping to have the guidance available to everybody by the end of the year, if not sooner. So it's very exciting there. So fundamentally, though, meta-aggregation is about essentially seeking that nuanced, deeper level understanding. But what's unique about meta-aggregation is that its role or purpose is to connect it to connect that evidence into synthesized findings that can inform practice, and from there we develop recommendations for practice. And that is something that's quite unique to the meta-aggregative approach. And it can do this, or the way it does this is that it's influenced by pragmatism and phenomenology. So those two approaches and the way that we go about undertaking meta-aggregation ensures that we're staying true to the original data, that we are always aligned with the phenomena of interest, and that we are thinking about practical approaches, gaining that deeper understanding, but thinking about practical ways in how this information can influence practice. So when we're thinking about questions that we may have and how meta-aggregation may be able to answer that, I just wanted to demonstrate, show here, there are a range of, so it's not just one particular question. You might have a question that's sort of condition focused, such as understanding how people deal with chronic pain management, social phenomena, different healthcare interventions, different types of specific behaviours and experiences. And here are just some examples of publications that relate to each of those. So this one is looking at living with juvenile diabetes, understanding community members' perceptions and practices to trachoma, looking at how people interact with healthcare professionals. So how does a postnatal woman interact with a healthcare professional? What was it like to give birth and have experience postnatal, like after birth, during COVID, and also looking at interventions. So looking at how people experience, what is their experience of a particular intervention. So as I mentioned, I lead the transfer science team, and so we are then pushing all of this synthesis knowledge into practice. And so this is really about applying evidence to practice. And there has been, I'm sure you would recognise that there is an influx of information. So this is very challenging for the individual person to do themselves, is to be able to grab hundreds of pieces of information and then work out what they're meant to do with that information to inform their practice. But there are some people that have developed a evidence-based healthcare pyramid, or around placing a hierarchy on the types of information that you would use to inform your practice. And so at the very top, it is having evidence integrated into healthcare systems. So that's ideally what we would be wanting to achieve. And from there, you would look at having synthesized summaries of evidence. So this is taking all of the information, having someone like our team at Transfer Science summarising that information and presenting it in useful resources. And ideally, those resources get integrated into the systems, and then it works its way down to guidelines, systematic reviews and studies. And this is just, I wanted to demonstrate for JBI where our resources sit. So we sit at that sort of that second level. I've flipped the numbers around, second level tier, and I'm just going to give some examples of how our resources, with the qualitative lens, how they are used for practice. So the types of resources that we have are evidence summaries, recommended practices, best practice information sheets, and the best practice information sheets I'll just touch on is where we link in with the evidence synthesis team. So that's having a systematic review of which we have worked with the authors, and we produce it in a format that is tangible for people who may not want to read a full report. So this is why transfer is important. It's about presenting information in ways that is digestible, useful to the end user. The audit criteria so our team develops evidence summaries, and from their best practice recommendations, and we develop audit criteria where possible that aligns with those recommendations. And that audit criteria sits within our implementation wedge. So if you're going to evaluate practice against a standard, that's where the audit criteria sit. So you can see we have a really strong connection with both synthesis and implementation. So I think we're quite the important people, the transfer part. So in terms of how we develop our evidence summaries, it's very similar to the systematic review approach. We have a very rigorous process. They are peer reviewed both internally and externally, and it's not just us, it's not just a single person, it requires a team. So it's a huge team of people that we work with, both internal to JBI and external, to be able to develop these resources. And then just to spend the last few minutes going through what some of these resources, how qualitative evidence can be useful. Here are just two examples of an evidence summary. And one is looking at the effectiveness of integrating caregivers into the rehabilitation of an older adult an older person that's been hospitalised. And so this particular summary of evidence is looking at, should we even be doing it? Is it effective to actually have caregivers involved in delivering care? And the other evidence summary shows where qualitative evidence can be really useful for that. It's understanding from a caregiver's perspective what it is like to be a caregiver with a loved one in hospital, and what do you need? What kind of what are your is there any information that you need? Like, what do you need in order to be able to have improved that experience? And so both of these summaries had recommendations, but they're very complementary to each other. So one of them says that yes, it can be effective, and where possible should be integrated. And the qualitative evidence summary provides some insight into what are some tangible things that you could do to improve that experience. Likewise here, this is on medical imaging. So this is about the patient's experience in undertaking a CT or an MRI. And so what we can learn from by unpacking patient experience is that people feel anxious, sometimes claustrophobic. So to be able to by understanding that, we are then able to develop some strategies that might help us help alleviate some of that. Likewise, for heart failure, people were happy to attend heart failure programs, but they found that when they left the program, they just forgot everything that they were told in the program. And so for them, what was really important was having social networks and support. And so understanding that can help continue on with the benefits of the program. Pressure garments, the use of pressure garments in a burns patient. So this is understanding what it's like for a person to be wearing a pressure garment. The quantitative evidence shows that there's usually a lack of adherence. So people usually take them off, not wear them. But understanding from a qualitative perspective is that the reasons for that is because it's itchy, it's red, they get sweaty and hot. And so a strategy, that a recommendation, is to have regular follow-up to address some of those issues that have been identified through qualitative research, so that we can address them earlier and not have them become a problem. And then this is one that I wanted to show you, that just showed how you can have different perspectives from different groups of people. So this is about a cancer patient, cancer patients returning to work, and it offers insight into the perspectives from the patient themselves, from the employer who is going to be receiving the patient, the cancer patient back into the workforce, and also from the healthcare professional and what and their role and their experience of helping that person. So qualitative research is really useful in being able to do that. So really over time. Sorry about that. So this is just, I want to just show this slide because it may be a bit confusing. We've been learning about systematic reviews and now I've just introduced evidence summaries to you. But I just wanted to show what the similarities and differences between the two are. So they both use a very systematic approach to its development. Evidence summaries aim to be focused at used at informed decision making, used at the point of care. And so therefore they're deliberately condensed, summarized into sort of 2 to 4 pages. And then there's a bit of an art form in how to do that. Whereas a systematic review is usually quite lengthy. We can develop best practice recommendations. So as I've showed you today, that from our evidence summaries, we can summarize the evidence with the group, our external groups that we engage with, develop recommendations that can align with the best available evidence. And our evidence summaries are living, so they are constantly being updated so that they are informed by the best available evidence. So this is my last slide. I just wanted to give any take-home message. It will be to understand that qualitative synthesis really does allow us to provide person-centered care. So by understanding the needs of the patient and or the healthcare professional, we are able to really deliver person-centered care, and that it's those nuanced bits of information that can be really useful for helping us do that. So with that, I thank you very much for your time. That's my last slide, and I will stop sharing.
Heartfelt thank you to Dr. Kylie Poddard for shedding light on the integration of qualitative evidence into practice recommendation. Your insight have provided us with valuable perspectives on enhancing healthcare strategy using qualitative evidence.
Thank you, Kylie. I think you're one of the first person to accept our invitation. And it's always great to hear from you.
Thank you very much. I look forward to the panel discussion.
Sure.
So our next speaker is Dr. Monica Arora. She's an executive director of Hriday, and she's a public health scientist working in the area of NCD prevention and control and adolescent health. She's a vice president, research and health promotion at the Public Health Foundation of India. She's the president of NCD Alliance, the founding chairperson of Southeast Asia NCD Alliance, and a founding GB member of the Healthy India Alliance. She serves on national and international expert committees on NCD prevention and control, tobacco control, ending childhood obesity, WHO Civil Society Working Group on NCDs, and has been a commissioner for the Lancet Commission on Adolescent Health. Her area of research interest is designing, implementing, and evaluating group randomized control trials, behavior research, including mixed method research, policy research, implementation research, rapid program review, and impact evaluation of policies and programs. So today, Dr. Monica will discuss how qualitative evidence influence healthcare policy. Let's welcome her to share her experience.
Thank you very much for that kind introduction. Can I share my screen?
Yes, ma'am.
Thank you. I hope you can see my screen.
Yes.
Perfect. Okay, so first of all, thank you very much for inviting me to this very interesting webinar and an area of research which is need of the hour, not only in India, but globally as well. So there are very few qualitative researchers, and as we all know that the evidence for qualitative systematic reviews and appreciating the evidence is a very recent phenomenon. And many research institutes still continue to believe qualitative research is a soft science. So initiatives like these, which actually help us strengthen the argument for why qualitative research and synthesis from qualitative systematic reviews is equally important. So just to bring everybody up to speed, and I am sure my earlier speaker has already talked about some of the basics, but just that I would like to highlight from my particular talk perspective, systematic reviews is considered as not only a methodology, but it is a technology as well, because evidence-informed policy and practice movement can be based on the evidence that emerges from qualitative systematic reviews. They also bring research closer to decision making, because decision makers don't have to transact a lot of qualitative papers or quantitative numbers to be able to make evidence-informed decisions. Also, these reviews use rigorous and explicit methods to bring together the results of primary research. So again, we get consensus statements and things which align together. Also provides reliable answer to particular questions. And most important is that the picture that emerges out of these reviews is not distorted. There are biases in primary research, and there are also biases in review process, which these reviews take care of. Coming to qualitative research as a methodology, since I'll be talking a bit more on this front, as we all know, it not only explores, but also provides deeper insights into real-world problems. Our randomized controlled trials always provide an experimental environment, but qualitative research is more real-world. It gathers participants' experiences, perceptions, and behaviors, answers hows and whys, which we are unable to get from quantitative research, where the quantitative research does provide us how many or how much, but why a particular association or causation is happening in a particular context is important to understand through qualitative work. It also has the ability to explain processes and patterns of human behavior for health seeking or healthcare, and can be difficult to quantify. These are measures which we are unable to quantify and can only qualify. It also helps expand and deepen the understanding of data or results obtained from the quantitative analysis. So most of us have been using mixed methods research to be able to enrich the research outcomes. Another context I want to bring in is why systematic approach to study a phenomenon within a particular context is important. It is because we are able to get lived experience, and when we are designing an intervention, it is very important that the community where the intervention would be instituted or housed should be having ownership to that intervention. And that happens only when we are able to get inputs from the community to be able to inform our research. Moving on, qualitative methods are also being used in implementation research now, which is an upcoming field of research being implemented by governments as well, to be able to evaluate not only the implementation of national programs, but also to be able to understand processes and impact of the national programs being implemented. So qualitative methods are an integral part of implementation research, and this research is a scientific study which uses strategies to adopt and integrate evidence-based health intervention into clinical and community setting to improve individual outcomes and benefit population health. The kind of questions that we try and answer through implementation science research is around outcomes which are feasibility, acceptability, appropriateness, adoption, penetration, and sustainability. So these are all very important aspects and measures which are now being looked at when we conduct research in communities. Also, how these qualitative research is informing policy, it definitely helps us define the policy question, look at how programs are implemented, determining the outcome measure by looking at subjective outcomes as well, instead of just having quantitative or objective outcomes. identifying successful initiatives and strategies. So what is working for whom in what context is equally important to understand when we want any intervention to be effectively delivered in a community. So understanding of context, mechanisms within which policies must be framed and implemented, and here policy would be interchangeable with the program as well. So policymakers do need qualitative systematic research because it helps them understand how or why a policy or program option is working or is not working. It summarizes the systematic review and provides evidence for decision making. Also, overview of systematic reviews helps in compiling solutions or best practices that can then be contextualized by the policymakers or can be contextualized by the practitioners. And policy briefs kind of provide a quick overview of evidence to policymakers to take decisions on whether they would like to have a particular intervention or a clinical practice instituted in their health setting or in the community setting. Advantages of qualitative research, it allows the researcher to gather rich contextual insights into people's lived experience of policy, program, and power dynamics, which is equally important. One example I would like to draw here is that I will be talking more about this research, but when we did community conversations with people with lived experience of non-communicable diseases, and in the conversation, the solutions provided in better management of their condition of non-communicable disease was that they are empowered to understand the disease and be able to provide effective management, not only for themselves, but anyone else in the community who may want to learn from their experience of navigating the health system. So definitely the patients who were wanting to become community champions said, yes, you can empower us. But in that hierarchy of health system, we as patients are at the lowest slab. So that power dynamics is equally important to understand. So we realize that we have to provide intervention not only at the community level with the players to become community champions, but also at the health system level to embrace this concept of community champions and patients being an expert in their own right. So that is how qualitative research helps in informing the policy and practice to be evidence-based. These are just quick examples of the types of systematic reviews which are needed in policy making process, and I can send the slides, but just I will quickly go through the steps in policy making. It is defining the problem, assessing potential policy and program options, identifying implementation considerations, promoting a climate that supports the use of reviews. These are various approaches. Producing reviews and review-derived products that address high-priority policy issues, and each example is provided of the approach. So anyone interested can read this article in depth by Levis JN, but also read through the slides. Packaging reviews and review-driven products for policymakers and stakeholders. Disseminating reviews and review products is equally important, how they are presented to policymakers and stakeholders, because we can write in Lancet and BMJ and the papers would remain there till they are not converted into policy briefs and layman's understanding as part of dissemination of those research. Also providing policymakers and stakeholders with the resources, skills, and opportunities to find and use these reviews and review-derived products when they need them. So when they are presented or when you are a part of an expert group committee, how you are able to synthesize this information and present to them is equally dependent on whether there will be incorporation of this evidence in the policy and the program that is being discussed. So where can qualitative evidence be used in a policy brief? They can be used to understand both the problem and the proposed solution, and also to identify those factors that need to be paid close attention to in their local setting if they want a policy option to be effective. So we have talked about understanding what is the underlying problem, what are the determinants linked to this health problem, and how it is understood locally. So it is very important to capture those local myths or understanding misbeliefs which may need to be tackled if we are addressing a risk factor or a disease. How options are perceived and experienced also needs to be looked at to be able to get acceptability. What might affect implementation, feasibility, implementation process, identifying key barriers, enablers, and our intervention should be able to address these barriers and use facilitators when designing the intervention. And how local context might affect sustainability and outcomes. So many a times we provide intervention in a community setting where we bring in a lot of expertise through the research team. And after the research project is over, all that effort goes waste till we don't institute that intervention in the community through existing mechanisms. So understanding that local context, social, cultural, economic, political factors that can sustain this intervention and the outcomes is equally important and worth investing right at the time of designing the intervention. Quick examples of some of our qualitative work that has influenced programs and policies in India. So Maitri was a group randomized trial. This was mobilizing youth for tobacco-related initiatives in India. So this group randomized trial was with 14,000 students in 32 schools in Delhi and Chennai. Grade 6 and 8 students were recruited and they were followed up for 2 years. This multi-component intervention to prevent tobacco use among school-going adolescents was designed. This intervention model was designed through a formative research with the students, teachers, parents. So understanding all the stakeholders who are important and how they can contribute to this intervention was understood, and this evidence-based intervention model was developed. After 2 years of interventions, we saw dramatic results where current tobacco use actually increased in the control group by 68%. And in the intervention group, there was a decline of 17%, very clearly highlighting if we don't provide intervention, tobacco use would increase at that kind of rate, and providing intervention can actually reverse this tide which the country was seeing at that point in time. Similar results were seen for intention to smoke and intention to chew tobacco. These all decreased in the intervention schools. And these results also, this was a group randomized trial, so it had a very strong process evaluation and qualitative research methods which were employed. So we conducted mediation analysis to understand what pathways led to the change that we saw, and we realized what factors actually need to be worked on. For example, normative beliefs about tobacco were significantly associated with reduction in students' intention to use tobacco. Also, students' perception of prevalence were significantly related to increase in contrast to students whose intentions to use tobacco were compared. So many a times when we ask the first question, how many students of your age do you think use tobacco? The answer actually was 90%. So those perceptions were in the first place flawed. So these need to be corrected, and we realized these were important intervention measures. Also, we did process evaluation. So we realized what worked and what did not work. So for example, we realized that communication between students and peer leaders and a higher proportion of students participating in classroom discussion was correlated. So the peer leader approach was an innovative phenomenon at that time, and this led to success of program and implementation in the classroom. Also, the games which were used, these were reported by teachers and peer leaders as well as community coordinators as the most enjoyed and popular intervention resource. So these kind of analysis are important when we have to scale up an intervention from a research setting to real world. So these evidence were presented to the Government of India in various expert group meetings, and this actually led to school health programs, including a component of tobacco control as part of National Tobacco Control Program. So NTCP was being discussed at that time, and it was being defined when this evidence was available, and we were able to give it as it is to the government for implementing throughout the country. And obviously, we gave what worked and what did not. So what did not work was taken off from the curriculum, but what worked was taken by the government. Another example is of working with patients that I talked about. So we started doing community conversations with the parents, with the patients, sorry. And this was again based on number of systematic reviews which had shown that engaging patients meaningfully helps in reducing the disease burden because they are better able to understand and manage their disease. So with that background, we started doing some qualitative research through community conversations with patients who were living with non-communicable diseases. And we did it throughout the country. And based on their consensus, we developed an India advocacy agenda of people living with NCDs, which advocated that patients should be meaningfully engaged because it's a human right and social justice issue. They need to be involved in prevention, treatment, care, and support, and also meaningful involvement meant engaging in activities in the health setting. So moving forward, again, these interventions and the evidence was presented to the government when the NP-NCD guidelines were being discussed. And in the revised operational guidelines, we see that the government did take up the evidence saying it is a good practice to meaningfully engage people with lived experience. Also, they included the India advocacy agenda of people living with NCDs and also suggested the mechanisms through Rogi Kalyan Samiti and how patients can be involved in the national program. So just quick examples that once we have evidence, we need to create public narrative around it to have people understand the outcomes of the research and its implications through op-eds, newspaper articles, and in webinars, etc., for policymakers to take cognizance of the evidence. Some more examples, which I'll quickly go through, but qualitative research showing that tobacco-free schools need to be going a step further now to start thinking about tobacco-free generation because the prevalence has started reducing among adolescents, but we need to think about new concepts of tobacco-free future generations. Monitoring through qualitative stakeholder engagement about tobacco industry interference, which is part of WHO FCTC Article 5.3. Just monitoring this over the years shows that Hriday started doing this in 2017, and other NGOs started taking up this monitoring, and we started seeing the industry interference score going down from 72 to 57, showing that monitoring and publishing these kind of qualitative feedback and stakeholder engagement interviews helps in reducing the policies and effective enforcement of such policies. Thank you. I'll stop here and I can take questions as required. Thank you.
Thank you, Dr. Monica, for enlightening us on the impact of qualitative evidence on healthcare policy. Your insight have provided us with a deeper understanding of the intersection between qualitative evidence and policy making. So we go on to our final keynote speaker. So final keynote speaker is Dr. JBI Menon. He is a distinguished cardiologist and public health expert with extensive experience in academia and clinical practice. Holding a DM in cardiology and an MPH, he has made significant contribution to the field of preventive cardiology and population health science. With a keen interest in venomous snakebite prevention and treatment, Dr. Jaydeep has received numerous awards and recognition for his exemplary service, including prestigious honors from the Indian Medical Association and the Society for the Physically Handicapped and the Infirm. He is also actively involved in various professional membership and serves as a technical expert on several esteemed committees and panels. His research interest is preventive cardiology, epidemiology of cardiovascular diseases, evidence synthesis, venomous snakebite, and its mitigation. So Dr. Jaydeep will share his valuable insight on what clinicians seek in qualitative systematic reviews. So let's welcome Sir to enlighten us on this crucial aspect.
Thank you, JBI, Dr. Chandrasekhar and Dr. Vinita for having me here. Can I share my slides, please?
Yes, sir.
You're sharing it from there?
Also, you can share it from there also.
Okay. I hope it's visible.
Yes, sir. You can put it in full screen.
Okay. So, thank you. And once again, what I'll be bringing in is my perspective as a clinical researcher as to what do I look for in qualitative systematic reviews. So I asked myself 6 questions. Why systematic reviews? So the content of my presentation goes thus. Why systematic reviews? Secondly, is a qualitative arm required in all clinical research? Thirdly, what extra does a qualitative research bring onto the table of evidence-based care and treatments? Fourth, a few case scenarios wherein I can highlight as to where qualitative arm is actually important. Fifth, the role of patient-related outcome measures in qualitative research. And lastly, the importance of qualitative research in implementation sciences especially. So starting with what the role of systematic reviews. Continuing on to what Kylie also mentioned, systematic reviews have risen in prominence as a means to identify, appraise, and then synthesize research. Systematic reviews are considered arguably to be at the apex of the evidence-based evidence pyramid hierarchy. But on the flip side to it is that systematic reviews are primarily randomized control trial and quantitative research driven. So what is the role of qualitative research here? When we talk of qualitative research, just everything is in relation to something else. Qualitative research is always assessed on the basis of quantitative research. Quantitative research, as the name implies, quantifies and it enumerates as numbers which make for an easy comparison and for statistical inferences. So when you're looking at a diabetic, you're thinking in terms of his random blood sugar, you're thinking in terms of his fasting blood sugar, postprandial blood sugar, or the HbA1c. But you're not thinking along the nuances of the disease process as such and what the individual patient or the individual actually goes through. Same so with the caregiver, that is his immediate caregiver and the caretaker of his disease as well. So what the qualitative research brings in is, it brings in that aspect of what the individual as a patient or the system or the policymakers or the polity, what they see and what they bring in as evidence to further research. So that is what qualitative research actually looks at. So qualitative research is pivotal in as far as assessing the adoption and acceptability as also in the planning of the research where input of all stakeholders are sought in framing, adapting, and contextualizing the intervention to local needs and culture. All this, I believe, is very important because when you're talking of a randomized controlled trial, it is always in a very sanitized environment where the effectiveness is looked at. The taste of the pudding is actually in eating it. a policy, a research becomes research of use only if it is embedded in the community. How does the community look at the research question? Is it acceptable to them? Will they adopt it? Can it be generalized to different contexts? Is what qualitative research actually addresses. Just as qualitative studies help format and give direction to an RCT in hybrid designs, systematic reviews in qualitative research too help give context to the research question and its efficacy. For me, qualitative research is especially important in two phases of a clinical trial. One is in the formative phase, where you bring all the stakeholders together, understand the needs of the community through the different stakeholders, and then address the research question. So there'll be a lot of iterations in the formative phase. So qualitative research comes in big in the formative phase, as also at the end of the study, towards the end of the study, where you understand the nuances that the trial process or the path process to the trial has actually been, whether it's in the environment of a hospital, a primary, secondary, tertiary care hospital, or whether it's in the community itself. Randomized controlled trials look at the cause and effect, and not as much as to whether the specific intervention can be can be upscaled. So the third question that I'd like to answer is, what does qualitative research actually bring in that the quantitative does not? Qualitative studies explore the beliefs. I think Kylie also mentioned this, explores the beliefs, expectations, and understandings of patients. They have the potential to influence healthcare decisions. When combining qualitative studies in a review, findings become more significant because they draw on a broader range of participants and descriptions. These reviews consolidate the body of knowledge on a topic, organizing and describing the characteristics of the studies, their methods, and their findings. So each part of this is important in the sense, right from after the research question is framed, how the whole path process towards the final analysis is what should be looked at in a hybrid model through qualitative research as well. As a result of this process, a new interpretation of the phenomenon is produced, whether you call it phenomenology or whatever, contributing to the understanding of the topic. Also, systematic reviews allow exploration of research design, of research addressing the impact of illness, patient experiences with healthcare, or organizational aspects of the care delivery. These reviews can also contribute contextual information to supplement evidence generated by RCTs. Systematic reviews of qualitative research address a phenomenon of interest and help building on what is gathered from RCTs. So I'll just come to the case scenario. So just to what I said thus far is that when you're looking at randomized controlled trials, you're looking at an individual and a certain part of the disease only, a reductionist approach to disease. Whereas when you're looking at an individual holistically, there are other parts of it, in the sense a typical patient of 60 or 65 years who's got triple vessel coronary artery disease there's a high, about 60 to 70% of them would be diabetic and hypertensive and also dyslipidemic. A third of them would have osteoarthritis. If above the age of 65, there's a high likelihood of cataract changes in the eyes and diminution of auditory function as well. So which one factors in how much in an individual is how the individual perceives it, and it is not for the caretaker to decide as to which is more important for him. Now, so with that in mind, I'll just paint a few case scenarios for you. Here, in a randomized controlled trial, where we look at the use of insulin or insulin analogs as compared with OHAs for the control of diabetes mellitus. Now, the majority of clinical trials would suggest that insulin or the newer analogs actually are more beneficial, both by way of control of the sugars as also in preventing the microvascular complications of diabetes. The wealth of evidence would suggest that, but what it doesn't tell us is the number of episodes of hypoglycemia that the individual goes through, individual or customized versions of how they take to being pricked twice or thrice a day, questions of lipoatrophy at the sites of infection of the sites of injection. How many of them actually go on to develop some cellulitis or abscess at the sites of infection at the sites of injection? These are not what are actually not the trials do not spell out as much as when you have a qualitative arm into it. So the path process of when you compare an OHA versus insulin, what should also be factored for is what the individual patient who is injecting himself or herself with insulin goes through, whether it's acceptable and adoptable by her, and whether he or she actually takes to it from the heart based on what he or she understands from what the clinical research actually tells us, and whether that can offset, whether the gains from the injection actually offset the pain that the individual goes through for the injection process as such. So these tend not to be looked at in qualitative studies. In quantitative studies, where the onus is on the HbA1c and the control of fasting sugar, PPBS, and maybe the target organ damage secondary to diabetes. Also, a second scenario that I would like to paint out is about how people with pain experience pain, and how, what the caregivers actually understand about that. So taking a pain of diabetic neuropathy, an individual with say 15 years of diabetes who's really limited by the neuropathic pain in both limbs. He doesn't get good sleep at night because of the neuropathic pain that actually wakens him, and he's limited in his activities because of the same. The same individual may probably be on hemodialysis for renal failure as well, and may also have triple vessel disease. From a clinician's point of view, we understand that the pain of neuropathy is limiting, is disabling, but is unlikely to kill him, whereas the triple vessel disease and the renal dysfunction is probably what can lead to his death. So when we look at it from the individual's point of view, the cardiac pain comes and goes, and it is intermittent. It doesn't come on a daily basis. It may come once or twice a month if treated well. The dialysis is something that he goes through, but the pain, the lancinating pain or the neuropathic pain is what is most distressing. But from the caretaker's point of view, when we look at the individual, the credence that we give to coronary artery disease and the renal dysfunction is far out of proportion to what actually disables him on a daily basis. So that is where the patient perspective of disease actually comes in, and that is what is captured best, not by quantitative research, but more by qualitative research. When we talk of pains, we can grade pains in different scales, Likert scale 0 to 10, or you can give different numbers. And when we look at disease scenarios, when you look at the quantitative aspects, you can classify dyspnea 1 to 4, NYHA 1 to 4. You can classify angina by the Canadian Angina Questionnaire. So here again, you have set precepts in the sense that walking one block. Many an individual above 80 years of age may not be able to walk a block, maybe not limited by angina, but may be limited by osteoarthritis. So these are the things, these nuances of disease are what are not captured from quantitative research, and there is where the qualitative aspects of what the individual patient goes through is best captured in qualitative research. Another good example would be the digital applications, especially for NCD care. Now, when we look at digital applications, when you look at anything in the community, digital AI related, it is not a bottoms up, it's more of a top down approach in which we start from the policymakers as to how much they think NCD is an issue and how much of money they can actually appropriate for NCDs and digital care, surveillance, monitoring, etc. Try to bring in other stakeholders like from the district medical office or the NCD state officer from the NCDs, and work your way down to the district program manager for National Health Mission, right down to the ASHA level, down to the level of the individual participant. In this case, maybe a case of an individual with diabetes, hypertension, or dyslipidemia. When you're looking at digital applications, what we have to ensure for is that people should have a smartphone, number one. people should have the net connectivity, number two, and more importantly, there should be uninterrupted electrical supply, which may not be there in all places all over India, especially in difficult to reach or tribal areas. So when we look at digital applications, if you were to do a clinical trial without going through the nuances of the healthcare system, I'm afraid the trial would fail. So it is very important as a part of the qualitative aspect of a trial, of the formative trial, phase of a trial, to bring in these stakeholders, understand the needs, and then go about planning as to how to embed a digital health application in the management of NCD care. So this, when we look at the qualitative aspects, like both of my previous speakers actually alluded or touched upon, it is more individual centric, patient centric, whether it be a digital application, whether it be a treatment term, whether it be an intervention by way of a drug or an intervention by way of a device, or whether it be a behavioral change. It is important to understand the individual's perception of what his or her needs are before deciding as to what the answer to that should be. So all these are best given from qualitative studies. Now, another important aspect of disease care which has come up in prominence of late is something that is called the patient-related outcome measures, where when we look at a randomized controlled trial, we have a primary objective, we have a secondary objective. Speaking from a very narrow cardiac lens or a diabetic lens, for most cardiac or diabetic studies, the outcomes, the primary outcomes would be the death, a myocardial infarction, revascularization procedures, or hospital admission with heart failure. Now, these are hard endpoints. But other than that, what does the individual who's on the clinical trial, where you're comparing a drug X or an injection X versus placebo, keeping all the other treatment aspects as such, what the individual goes through in the path process is what is actually measured from what the patient or the individual reports as outcomes. The outcomes may sound very innocuous to us in the sense that he or she did not get good sleep last night, or may have constipation, or the number of times he or she has to use the urinal is more. But all these are what distresses the patients, but they do not measure up as hard outcomes. So do we give credence to these symptoms? Isn't it important from a patient's point of view, especially in this age of customized medicine? All these should be given their due, and that is what the qualitative arm actually brings in. A growing interest in the synthesis of data generated by individual qualitative studies it's been suggested that by combining the qualitative studies in a review, the findings become much more robust, significant, because they draw on a broad range of participants and descriptions. These reviews consolidate the body of knowledge on a topic, organizing and describing the characteristics of studies, their methods, and the findings. As a result of this process, a new interpretation of the phenomenon is produced, contributing to the understanding of the topic, to a better understanding of the topic or the research question as such. For example, systematic reviews, especially when qualitative, allow exploration of research addressing the impact of illness, patient experiences with healthcare, or organizational aspects of the care delivery system. These reviews can also contribute contextual information to supplement evidence generated by RCTs. So the last bit of my sixth question was implementation sciences. Now, more and more implementation sciences are on a pedestal and are what are seen to be mainstream. What has been seen effective or efficacious in the sanitized environments of a randomized clinical trial need not be so in the pragmatic environs of a clinical care setting, whether a hospital or the community. So when we look at the implementation sciences, this again is what Dr. Monica alluded to, the acceptability, the generalizability, the adoptability, the economic aspects of that. These are what the implementation sciences actually look at. Is it acceptable? Will it be adopted by the community? Can it be taken up? Can it be upscaled? Is it contextual? These are the things that implementation sciences actually look at. And implementation sciences are heavily, qualitative research is heavily embedded in implementation sciences, where the p-values or the statistical inferences are not as important. The input from key stakeholders, including study participants, patients, is vital in assessing the success of an intervention, whether behavioral, policy, drug, procedural, or digital tools, etc. The success of an intervention is measured from both its efficacy as well as in its scale of adoption and acceptability. So when we're talking of implementation sciences, now in general, when we say adoptability, acceptability, or fidelity, we usually do not give any numbers to it. So how do I say that it is adoptable, that it can be upscaled, that it is generalizable? More and more the studies have moved to giving a certain percentage to it. So if you've rolled out an intervention or a behavioral change in a group of 100 families, if more than 70 or 80% of those families adopt it and think that it can be continued long term, that is where I set a definition of that it is adoptable. So typically in implementation sciences and in qualitative research, though we do not give percentages, more and more studies actually suggest that when we say adoptable, scalable, etc., we can actually give percentages to this. So I'll end at this. I've just brought in a clinical researcher's perspective of qualitative research and why it is especially important in generating evidence, especially from the lens or from the viewpoint of the participant. This is in case the individual patient, his immediate caregiver, the family, and the caretaker, that is the doctor who's taking care of him, and the health system as such. I'll end at this, and if there are any questions, I'll be more than happy to take them. Thank you. I'll just end with the last couple of slides. When we're looking at qualitative research, what we're looking at is not meta-analysis, but what we call meta-synthesis, which is a critical review and analysis of process data or the themes, domains, and descriptions generated by multiple qualitative studies. The goal of meta-synthesis differs significantly from meta-analysis, which is what is seen in quantitative research, in meta-synthesis being interpretive rather than aggregative. It seeks to generate understanding or interpret explanations of a phenomenon. So the questions for qualitative synthesis are, related to the interventions are, how do people experience the identified outcomes? Why does an intervention work or not work for some, and why does it work for some? What are the aspects of intervention which are valued or which are not valued? What factors facilitate or hinder successful implementation of a program, service, or treatment? And how can a particular intervention be upscaled? Thank you. I'll end at this. And if there are any questions, I'll be more than happy to answer them.